So I'll be talking on radiological interventions in diabetic foot and management. So the epidemiology of diabetic foot ulcer tells us that it is one of the most serious complications of diabetes, and about 50% of all patients with type 2 diabetes mellitus develop an arterial diabetic foot ulcer. 85% of all amputations are preceded by an ulcer, and up to 70% of all lower leg amputations are performed in patients with diabetes. So that is the seriousness of the problem. So diabetic peripheral vascular disease is characterized by vascular inflammation, which is a risk factor for peripheral arterial disease and is associated with elevated CRP. Diabetes also causes endothelial cell dysfunction. So there's derangement of nitric oxide bioavailability at the vascular level. And diabetes also leads to a hypercoagulable state, which results in microvascular occlusions. So before we go into diabetes, we have to differentiate diabetes peripheral arterial disease from atherosclerotic peripheral arterial disease. So diabetic peripheral arterial disease generally is localized to the lower leg, that is mainly below the knee. The iliac arteries and the superficial femoral artery can sometimes be involved, but they are involved in less than 10% of cases. And usually the involvement is associated with below the knee involvement of the arteries. Atherosclerotic disease, on the other hand, generally involves the iotoiliac and the iliofemoral vessels, although the disease is more pronounced in the foot because of very low flow seen in the foot. The pattern of involvement in diabetic peripheral arterial disease is generally long segment, whereas it is short segment in atherosclerotic PAD. It is medial sclerosis in the diabetic PAD, and diffuse intimal calcifications are seen in the atherosclerotic disease. Symptoms, the diabetics are generally pain-free due to associated neuropathy, so they are pain-free ulcers. There may be rest pains and claudications, which are less frequent. Ischemic ulcers are more common in atherosclerotic PAD, and their painful ulcers and rest pain and claudication are present and can be extensive. So the treatment for some of which has already been outlined for diabetic foot ulcer is conservative management, comprises of conservative management, primary amputation, surgical bypass, and endovascular revascularization. The mainstay of treatment is always medical therapy. The best form of medical therapy available should be given. Patients should be given supervised exercise. They can be given antiplatelet drugs like cilostazol, aspirin, and clopidogrel, vasodilators like pentoxifillin, and we should maintain the blood sugar, manage diabetic control, also keep a low cholesterol level, and ask the patient to stop smoking and try to control their obesity. So now it is widely recognized that endovascular interventions can play a crucial role in healing of wounds due to diabetes and prevention of amputation in these patients. So the aim of endovascular therapy is revascularization with the help of balloon angioplasty. And this can reduce major amputation rate from 59 to 8% compared with patients who do not undergo this kind of treatment. So the indications again are non-healing ulcers without infection and gangrene. So non-healing ulcers, which are infected or not infected, and gangrene are the two indications. And patients who are poor surgical candidates are particularly taken up for these kind of procedures. Most of these patients are poor surgical candidates because they have high risk of they are high risk for surgery because they have associated involvement of other vessels also, including the coronary vessels. There may be non-availability of good venous material to create a conduit, or there may be segments of the arteries where a proper anastomosis cannot take place because the peripheral arteries may be heavily calcified. And the goal of treatment is preferably to recanalize the vessel that is feeding the area of the ulcer. And the extension of the revascularization should extend up to the pedal arch and, if possible, beyond. If you're not able to collateralize the vessel that is leading to the ulcer, we can still open up other vessels, and that will provide a collateral pathway. If all vessels are affected below the knee, we should try to open up all vessels. But if it is not possible, try to open up at least one vessel. There's an angiosome concept that actually divides the human body into multiple 3D segments. And when it comes to the foot, we can see that the dorsum of the foot is primarily supplied by the anterior tibial artery. The medial aspect of the foot as well as the plantar aspect are supplied by the posterior tibial artery, and the heel is supplied by the peroneal artery. So whenever you get ulcers in these areas, we should try to recanalize these particular arteries. So case selection is very important, and there are several determinants of and adverse outcomes are very important whenever we are doing endovascular recanalization. And for counseling the patients, it is very important. This case selection is very important so that we can counsel them properly. So there are some patient-specific determinants of adverse outcome and some are lesion-specific. So the patient-specific determinants are elevated blood glucose levels. We know that diabetes causes vascular inflammation, and this causes smooth muscle proliferation and leads to high restenosis rate and amputations. So if you take a non-diabetic person, the primary patency in intrapopliteal disease is about 46%, whereas that in diabetics is only about uncontrolled diabetics is only about 16%. And the patency rates will reduce to half if the lesion involves the iliac or the superficial femoral arteries. Then the location of lesion can also affect the outcome. If the lesion is in the higher up, that is in the iliac area, the patency rates are better than the femoral-popliteal lesions, which are better than lesions involving the below-knee arteries. Then presence of a long lesion, presence of a total occlusion, presence of a poor outflow vessel, that is the vessels distally are poor in type, like they are heavily calcified or they have multiple stenosis, presence of calcification, thrombosis, ulceration, involvement of branch points or multiple tandem lesions are all determinants of poor outcome, and the patient has to be counseled accordingly. So before we take any patient for interventions, we do some basic blood test. We start the patient check his glycemic control, start the patient on aspirin and clopidogrel, at least 75 milligrams. It should be started 3 to 5 days prior. And we do the essential bleeding test, platelet count, PT and INR, renal function test, blood sugar level should be assessed, and potassium in cases where there is massive tissue loss or gangrene. So the access routes that we planned are generally determined by the lesion location. So if you have an iliac lesion, we would like to take a retrograde access through one of the femoral arteries, or we can come and take a brachial artery access and come from top. If you have a lesion that involves a common femoral artery, we usually take a contralateral access so that we get some space to actually negotiate across the common femoral artery. If you have involvement of the superficial femoral artery, we will take an antegrade access into the common femoral artery. And for superficial artery lesions and for longer lesions, sometimes we can take access both from above and below, whether that is from the popliteal artery or going down to the dorsalis pedis artery or the posterior tibial artery. So there is a CTOP classification, which actually is based on plaque morphology, and it tells us that what kind of routes we can take. In general, if the lesion is less than 10 centimeters in diameter, we will generally take one access, that is an antegrade access from top. But if the lesion is larger than 10 centimeters, then generally we try to take 2 accesses. So if the lesion is of a type 1 kind, that is the upper part of the lesion has a concavity upwards, we can take 1 axis. If the lesion has concavity both above and below, or a convexity both above and below, like type 2 and 3 lesions, we may need 2 accesses. And if it's a type 4 lesion, then we take an access generally from below if it's a longer lesion. So the technique is that in below the knee affection, simple balloon angioplasty is all that is done. And we generally do low pressure inflation and low pressure prolonged inflation of the balloon. And it generally gives a good result. And we don't need to generally place stents. Procedure time is a complication time. So we have to do the procedures really very fast, because we already know that the vessels are inflamed and there's a chance of thrombosis. So the lesser time we take to doing a procedure, the lesser chances that we'll have shorter complication time. So it's better to use longer balloons, use slightly shorter procedure times for dilatation. Like for example, we use balloon dilatation, say for about 30 seconds to a minute. And we can use inflation devices because they provide more accurate inflation than just simply inflating balloons by the hand. So this is a simple case, and where here you can see that there are 2 narrowings in the distal part of the superficial femoral artery. And what we simply do is take an antegrade access in the common femoral artery just below the groin, and a guide wire is negotiated across these narrowed arteries, and balloon angioplasty is done with this kind of angioplasty balloon. This is called a plain old balloon angioplasty. It's a simple PTA balloon catheter, and you can see that it has a smooth outline. It is a non-compliant balloon. That is, if it has a diameter of 8 mm, when you inflate it as best as you can, it will not go beyond 8 mm in diameter, and it will not generally conform to the vessel, like, so it will take its maximum dimension when fully inflated. And this is the result that you're seeing, that there's a significant improvement after angioplasty. So then there are also other balloons that are being used when they are used in situations where plain old balloon angioplasty does not work. And this is a cutting balloon, and where you have actually small arthrotomes. They are like small blades, very thin blades attached to the sides of the balloon. And they are particularly used when lesions are severely calcified, they are recurrent stenosis, and fibrotic lesions are there. But data supporting the superior efficacy over plain old balloon angioplasty is not yet currently available. Then you can use drug-eluting balloons. They are generally coated with paclitaxel, which stops formation of microtubules in smooth muscle cells, and also is supposed to prevent neointimal hyperplasia. But systemic reviews, systemic review from Katsanos et al. Has suggested that there's an increased risk of death following use of these balloons. So the endpoints of balloon angioplasty, how do you tell that an intervention is successful? Most of the time, we are not going to get very pristine results by doing endovascular interventions. The main aim here is to restore adequate flow to the leg arteries and to the foot. So when if the imaging shows less than 30% of residual stenosis, it's a good result. And there should be hemodynamic reduction in pressure from the non-affected sides across the affected side by less than 5 millimeters of mercury mean, or less than 10 millimeters of mercury systolic. There should be restoration of the dorsalis pedis artery pulses, and the post-intervention ankle brachial pressure index should improve by more than 0.15. Professor Damir had already said what the ankle brachial pressure index is. It should be actually more than 0.9 at least. 0.9 to 1.3 is normal. If it's less than 0.9, it's a problem. So sometimes you also get complete occlusions, and these are usually more commonly seen in the thigh, and you get complete occlusions. And sometimes you have to go across these. There are a number of techniques used to go across these lesions. You can go by an intraluminal approach, that is through the plaque, or you can take a subintimal approach where you make the wire cross subintimally and then re-enter the lumen distally, and then you do your angioplasties. A number of devices are available. You have crossing devices which help you to cross the plaque. Some of these are the front runner from Cordis. There's a crosser catheter from BD, and a Wildcat Avinger from Avinger, which cross with the help of blunt dissection and mechanical rotation. You also have re-entry devices. Also have re-entry devices which help you to enter the true lumen once you've gone subintimal. So some of them have sharp cannulas through which a wire can be passed, and then you can enter the true lumen once you've gone subintimally and come back into the true lumen once again. So now I'm just going to show you some cases that we've encountered here. This is a case of 57-year-old male with diabetic foot. He had end-stage renal disease, non-smoker, hypertensive, post-renal transplant, and a history of amputation. He had ganglion of the right toes. I don't know if this is getting covered here. So if you see his right toes, you'll be able to see that he's got loss of few toes. He had a history of ganglion of the right toes, for which he underwent amputation a year ago. And he also had angioplasty done after the amputation. Now he presented with a non-healing ulcer on the left great toe. So you can see that there is some blackish discoloration at the tip of the left great toe. And this was his initial angiography runs. You can see that there is a complete occlusion. There's a stenosis of the multiple stenosis are seen in the anterior tibial artery. So as we said, by the angiosome concept, the dorsum of the foot generally in that area would have been supplied by the anterior tibial artery. We can see multiple arterial narrowings of the anterior tibial artery. Similar findings are also seen in the peroneal arteries and the posterior tibial arteries. So what we should have attempted was to at least recanalize the anterior tibial artery, and angioplasty has been done, and you can see that we've significantly dilated the anterior tibial arteries, and now there's good flow to the foot. And this was another case. He presented with blackish presented with blackish discoloration of the right second toe. And this happened because of wearing tight shoes. He had already undergone an amputation of the great toe a year back. This was his DSA image, which showed focal narrowings of the posterior tibial artery. So we initially did a dilatation with a 3.5 mm balloon here and distally of the posterior tibial artery with a 2 mm balloon. And we also used a drug-coated balloon of 3.5 mm across these lesions. And this was the check angioplasty runs, which showed that those stenosis have now gone and there's good runoff into the distal foot. So this was his ulcer initially, and you can see that after a few months, there has been significant improvement now. This was another case who presented with a grade 2 swelling and some blackish discoloration on his grade 2 with some inflammation. And you can see that the femoral artery is normal, the popliteal arteries are normal, but when you see the leg arteries below the knee, you can see that there's a complete cutoff of the anterior tibial artery, and there are multifocal narrowings in the posterior tibial artery. We tried to attempt to recanalize the anterior tibial artery, but it was not possible. So then we had to actually do a recanalization of the posterior tibial artery. We planned that we should at least recanalize the posterior tibial artery so that we can get some kind of collateral flow to the foot. So dilatation was again done by 3.5 mm balloon. And this is the result after the angioplasty. You can see the ATA is still cut off, and there's improvement of flow across the posterior tibial artery, and there's flow into the foot via collaterals. And this is the result after a few months, where you can see that there is healing of the ulcer. So residual stenosis is sometimes a problem. You can do angioplasty and you may not achieve results. So one of the problems with below the knee interventions is vasospasm. You can use rigorous spasmolytics during the procedure. We use nitroglycerin. There are other drugs like lignocaine which can be used. And spasm can be misleading sometimes, and it may present a picture of failure. So what we do generally is when we have failed a procedure or routinely after every procedure, we always give 24 hours of heparinization. So this is just one of our cases. Here you can see that there is a long segment occlusion of the superficial femoral artery. This is the area of the knee and the upper leg, where you can see that you can barely recognize the anterior and posterior tibial arteries and the peroneal artery. This is the distal aspect of the leg. You can see that this is the anterior tibial artery and this is the posterior tibial artery. So we tried to recanalize this antegradally. We're using a guide wire and a catheter combination. So much of this recanalization we also do under ultrasound guidance. We put ultrasound probe on the thigh, and it helps us to see whether the wire is going into the true lumen or not. And we were not able to cross much beyond, so we took an access from the dorsalis pedis artery. If you can see this image, you'll be able to see that there's a microcatheter here also. And there's a microcatheter from top. And we were able to guide ourselves gradually into the anterior tibial artery. Then balloon angioplasty was done. And this was the run after the recanalization. So you can see that there is hardly any change after the angioplasty has been done. And this was the initial cutoff of the superficial femoral artery. All that you can see, there's a short line of recanalization that can be seen. The distal runoff is also not very impressive. So we thought that we had done something really bad to this patient. But however, when we checked after 24 hours, the dorsalis pedis artery was still patent, and the patient came back for follow-up, and he still has a patent pulses. So sometimes it's not always that you will get a good result. Most of the time, quite often you get bad results because the arteries are in bad shape. And like I mentioned before, the idea would be to do the interventions fast. Do not spend a lot of time. Use longer balloons if you have longer lesions, and try to do angioplasty and try to get some kind of a result rather than getting a perfect result. So in conclusion, several technical innovations are available for endovascular interventions in below the knee arteries and diabetic foot, and all are aimed at healing, ulcer healing and limb salvage. Most new techniques have not been proven in clinical trials to improve the already very high percentage of ulcer healing that we achieve with plain old balloon angioplasty. But revascularization of below the knee vessels needs experienced hands, and it needs teamwork of surgeons and endocrinologists and a right set of devices tailored for each case. Thank you.